Okay, so these are the objectives. As always, I won't bore you with it. It's self-explanatory. You can read it comfortably at your home. Reference, of course, is Guyton. That's why I told you before the lecture, this is quite long because it covers 3 chapters in Guyton alone. Chapter 63, 64, and 65. It's also in Gano, but most of the topics here in my PowerPoint is derived from Guyton. Okay, so a little bit of review of anatomy. You have your tunics or coverings of your GIT from your small intestines to the large intestines, right? They have the same tunics. You have your serosa. By the way, my dear students, one thing to know if it's a retroperitoneal organ versus an intraperitoneal organ. You know what I'm trying to talk about, right? When a portion of your gastrointestinal tract is inside your peritoneum, we call that as your intraperitoneal organ. When it goes back and doesn't have a covering of your peritoneum, we call that as your retroperitoneal organ, right? How to distinguish the two? The outer layer of your intraperitoneal organ is covered by a serosa. So when they quiz you in the anatomy, when you see a serosa there, it means that that portion of your GI tract is inside of your peritoneum, if it's a serosa. But if it goes back, like in your duodenum, you know, your duodenum that goes inside, and then the second portion will go back to the retroperitoneal space, and it won't have a serosa, but it will have what we call your adventitia. So that's the difference of the two. When you see the outer covering of your GI tract, a little bit of anatomy trivia to help you out in your histology. Serosa, it means that that portion of your GI tract is inside your peritoneum. Adventitia means it is a retroperitoneal organ. Now, after you peel off that serosa, you have 2 layers. You have your outer layer and inner layer of muscles, right? Your longitudinal and circular layer. After that, you have your submucosa and, of course, your mucosa. Now, this is the histology of that. As you can see, serosa, it means it's in interperitoneal organ. You have your longitudinal muscle outside, and inside you have your circular muscles. And after those 2 inner and outer muscles, you have now your submucosa, which houses your Meissner's plexus. There are 2 nerve innervations that you need to know when it comes to your GIT. Your Meissner's plexus and your Myenteric Textures. As you can see, your Myenteric Textures. Where's the Myenteric Textures, Dr. Bautista? Wait. So everybody can appreciate it. Myenteric Textures is located in between the longitudinal muscles and your circular muscles. So you know it has to do something with your GIT or smooth muscles in your GIT. Okay? While your Meissner's plexus or nerve endings is located between your submucosa and your mucosa. So you know, out of the 2, this has to be related to the secretions inside of your GI tract. This one for the contractions of the muscles. This one is for merely for your secretions. But, as you know, your GI tract has an enteric nervous system, meaning it has its own signaling based on the hormones and secretions that is inside of your GI tract. So those 2 nexuses that we're talking about communicate with each other. Okay? So again, Meissner's for glands, that secretions inside of your GI tract, and your Myenteric Textures is responsible for the contraction of your smooth muscles. And as you know from your musculoskeletal module, the smooth muscle, they differ because they don't have a striations, because their actin and myosin is arranged in a manner differently from your skeletal and cardiac muscles. But they do have your actin and myosin for contractions. Okay? Am I going too fast? Can you still follow?
Yes, Doc.
Okay, good. Okay, so as what I've been mentioning, your smooth muscles for your GI tract, they contract in a different manner. Unlike your skeletal muscle that is dependent on your neuromuscular junction, and unlike with your cardiac muscles that they are dependent on the nodal cells, SA node, AV node, your Purkinje fibers, this one has a channel that produces a slow wave or what we call your spike potential. What do I mean? There are ions going in and outside of the cell that is mediated by a pacemaker, which we call your interstitial cells of Kaha. Okay? If the SA node is for the heart, you know that in your GI tract, the pacemaker that initiates the slow waves of your GI muscles are your interstitial cells of Kahan. Or what does it do, Dr. Bautista? On the right side, it lets calcium in and out of your GI muscles, your smooth muscles. When calcium comes in, calcium comes out. Calcium comes in, calcium comes out. As you can see, it generates what we call your slow waves. It only produces an action potential if at the peak of that depolarization or threshold, you have another stimulus. What's that stimulus? I'll show you in a little while. So again, you have what we call in your smooth muscles, your slow wave or your spike potentials. This is specific for your smooth muscles in your GI tract. Our pacemaker is your interstitial cells or Kaha. You have rhythmical changes in the membrane potential caused by various sodium channel that goes in and out. So slow waves are unique to GI muscles. Intensity usually is only 5 to 15 millivolts. So that's how much sodium is coming in and out of those cells thanks to your interstitial cells of Kahal. Frequency ranges in different parts of the GIT. It can be at around 3 to 12 per minute. So that is the normal peristaltic wave of your GI tract. So when they ask you how much, what do you call this? A peristaltic wave is normal, it's around 3 to 12. Okay, because that's the action potential that's being generated to your smooth muscles. So as you can see, to sodium coming in and out to your interstitial cells of Kahal, and then you will have a stimulus at the top of that wave, and then you will have now what we call your action potential. What are those stimulus? It can be due to acetylcholine, it can be due to the stretching of your GI tract. Okay, so again, there's your calcium channels. Channels responsible for action potential allow large numbers of calcium to enter along with smaller numbers of sodium and therefore called calcium-sodium channels. So what are those, Dr. Bautista? So again, the slow wave is potentiated by your sodium coming in, and then you have a stimulus, stretching, acetylcholine from parasympathetic at the top of that slow wave, and then you have now the influx of that calcium and sodium going in, and then now you will have generated that action potential. Once you generated an action potential, your smooth muscles now will contract. So that's how motility works in your GI tract. These are much slower to open and close than are rapid sodium channels of large fibers in your skeletal muscles or even in your cardiac muscles. Accounts for the long duration of action potentials as well. Okay, so what can give you that spike potential? Let me repeat this statement again. So this is generated by your interstitial cells of Kahal. Sodium comes in, sodium comes out. Once a stimulus comes in, you will have what we call your spike potential. Unlike with your skeletal muscle, neuromuscular junction, sodium, potassium, depolarization, muscle contraction. For cardiac muscles, right, you will have sodium going in, calcium and potassium going out, you have a plateau, and then you have your potassium going out. So this is the for skeletal muscle. For your smooth cardiac muscle, for smooth muscles in your GI tract, you have what we call your slow wave potentials, and then a stimulus will come in, whether it's acetylcholine, stretching, and then you will have what we call your spike potential. And that's the time you will have a contraction of your smooth muscles. Okay, so resting membrane potential is around negative 56. Slow wave travels 15 to 5 to 10, 5 to 15, right? So it increases it to around 40 or 50, depending on the signal, for 5 to 15. And then you'll have that factors that depolarizes it and put it into a spike potential. So what are those? Stretching of the muscles in your GI tract. May I ask, my dear students, what can stretch the muscles of your GI tract?
Food.
Food, very good. Depending on the food, right? big bulk of food can stretch the muscles of your GI tract. And then you will have now your peristalsis. Acetylcholine is also a neurotransmitter that can do a spike potential on your GI muscles. Parasympathetic, of course, our rest and digest, and several specific gastrointestinal hormones that we will run around a little while. Okay, important factors that make membrane potential more negative or hyperpolarize the membrane and make the muscle fibers less excitable. What can give a negative peristalsis or make it hyperpolarized, so it will be more difficult to depolarize, meaning the opposite of what can stretch it or what can stimulate it. The effect of your epinephrine and norepinephrine. Of course, sympathetic. Remember, when you are in danger, you don't want your stomach to contract. You're running away from the lion or danger, and then you'll have a diarrhea. Oh, that's dangerous. Or stimulation of your sympathetic nerve that secretes mainly your norepinephrine at their nerve ending. So just remember, your parasympathetic helps in the peristalsis or contraction of your smooth muscles, while sympathetic inhibits it. Okay, so I talked about the two neuronal or plexuses that is located in your GI tract, right? The myenteric plexus, or the other name, I might use this in the exam. The myenteric plexus is called also as your Auerbach's plexus, one and the same. Okay, they are located between the muscles. So as you can see, they are the ones responsible for your peristalsis and the one that secretes your acetylcholine. Also, in the submucosal plexus, you have your Meissner's plexus. Okay, so as you can see from this diagram on the right, both of them, from the myenteric or Auerbach's and your submucosal or Meissner's plexus, they have a communication of each other based also on sympathetic and parasympathetic and hormonal gastrointestinal secretions. Okay, so please take note of that at the back of your mind first. So you can influence, in short, my dear students, your submucosal plexus or Meissner's plexus can influence your myenteric or Auerbach's, and Auerbach's and myenteric can also influence your submucosal or Meissner's plexus. They talk to each other. Okay. Okay. So what are the neurotransmitters that we will encounter today? Of course, acetylcholine for parasympathetic, your norepinephrine, serotonin, dopamine, CCK, submastotin, and your VIP, somatostatin. We'll go around this in a little while. I have a table for you, so you will easily remember all of these neurotransmitters and hormones. Acetylcholine is the most often excitatory transmitter in your gastrointestinal tract. Norepinephrine almost always inhibits it. Epinephrine reaches the GI tract mainly by the blood after it's secreted by your adrenal medulla in times of your adrenaline rush or emergencies. Maybe that statement again. For parasympathetic, of course, it's acetylcholine. For sympathetic, it's your norepinephrine. But if your epinephrine is secreted in your GI tract, which comes from your adrenal medulla, not cortex, okay? Your adrenal medulla, it also inhibits your secretions and peristalsis. The other aforementioned transmitter substances are a mixture of excitatory and inhibitory signals. Okay, so as what you saw for the parasympathetic, you have your cranial parasympathetic, sacral parasympathetic that can innervate your what do you call this? Your gastrointestinal tract. Your paracranial innervation by the way of your vagus nerve. Okay, the esophagus, stomach, pancreas, and half of your large intestines. We have what we call your vasovagal. When your gastrointestinal tract stretches or has a presence of food, it sends a signal to the vagus nerve up to your brain. And that sensory will also go down to the vagus nerve and contract and stimulate hormones and acetylcholine to your GI tract. That's why they call it vasovagal reflex. They also stimulate the vagus. The effector or the effector nerve is also the vagus. That's why they call it vasovagal. Okay, you have your sacral parasympathetic innervation by the way of your pelvic nerves at the distal half of your large intestine. So those are the stimulatory, these two. While, as you know, sympathetic can be inhibitory activity of your GI tract. They oppose your parasympathetic nervous system. Okay, so there it is. Your parasympathetic to vasovagal, as what I mentioned, for cranial end of parasympathetic, and sacral to your pelvic area for stimulus of the latter half of your large intestines. Your CNS, sympathetic to your ganglia of the celiac, superior mesentery, and inferior mesentery, innervations of your sympathetic nervous system. I hope you remember that in sympathetic, right, they have a short preganglionic and a long postganglionic. While parasympathetic has a long preganglionic and short postganglionic. Okay, if you still remember that. Okay, so this is the innervations of your gastric muscles. As you can see, you have your circular and longitudinal muscle, and they talk to each other via your interneurons. They are mediated by your myenteric ganglia and your Auerbach's ganglia. Okay, so I think I have 3 questions here. What controls the peristalsis of your GI tract? First and foremost, your gastrin. Gastrin is secreted by the G cells, mostly in the antrum of your stomach. Question number 5. It is also secreted by your duodenum and jejunum. What can stimulate its secretion? If you have protein inside of your stomach, in the antrum, duodenum, and jejunum. If you have food and nerve innervation via your acetylcholine. What does gastrin do? It stimulates the secretion of your gastric acid to your T cells and G cells. Okay. Second, my favorite, your CCK. Your CCK is stimulated by the presence of protein, fat, and hydrochloric acid. It is secreted in the duodenum and small parts of your small intestines, but mainly in your duodenum. Its action, my dear students, is to stimulate pancreatic enzyme, bicarbonate, and this is the one that stimulates the contraction of your gallbladder. That's why the reason for this is that we inhibit, or we, especially for those patients that has a gallstone, we tell them not to eat fatty food for 2 reasons. It can stimulate your CCK, and secondly, it can contribute to making more stones in their gallbladder. Okay, so it inhibits gastric emptying time. What does that mean? Because your stomach just poured in hydrochloric acid, just poured in fat and protein in your duodenum. Your duodenum now will be secreting CCK, duodenum and ileum, which is secrete CCK, that will go to the pancreas and to the gallbladder to release its enzyme for digesting that fat and that protein. Hence, also, it will stop and tell the stomach, hey, wait, I'm still digesting food. Can you slow down and do not increase the emptying of the food to the duodenum? Or do not put it to the duodenum yet, because I'm still digesting the fat and protein that you just given me. Okay, so that's the work of your CCK. Unlike with your gastrin, gastrin is aiding the more production of your acids and mucosal growth. Okay, secretin is stimulated by acid and fat. It is secreted by your S cells of the duodenum, jejunum, and ileum. So both of them are secreted by your small intestines. This stimulates pepsin secretion, pancreas, and bicarbonate of your biliary tract and your exocrine pancreas. This one, my dear students, like your CCK, inhibits your gastric acid secretion. Makes sense, right? Acid that was just poured into the duodenum, it will secrete secretin, and it will tell your stomach, hey, wait, I still have acid here. So that's the action of your secretin. Please listen. Your GIP, this one, if anything that you should take out regarding this lecture, or should learn regarding tonight in this lecture, because definitely you will use this in your clinical practice. Your gastric inhibitory peptide is stimulated by protein, fat, and carbohydrate. The three food groups, right? Macromolecules, protein, fat, and carbohydrate. Once we eat food, it is secreted by the K cells of your duodenum and jejunum. So why do we need to know that, Dr. Bautista? Because, my dear students, it is stimulating the release of insulin from your pancreas, and it also inhibits acidity in the stomach. Oh, why do we need to know that? What's the clinical factor of your GIP or gastric inhibitory peptide? Because when you have a diabetic patient and she's going into a hypoglycemia, no sugar, right? Going into the muscles, hypoglycemia, but plenty of sugar in the blood, right? Which is better to infuse to, which is better to infuse to her system, glucose to the IV or glucose to the stomach? Hello?
Stomach.
Why, doctor? Why? Are you still with me, students? Are you still here? Oh, Dr. Bautista is hypoglycemic, and you want to raise the sugar or put ATP in my muscles because I'm very lethargic. You know, I'm going into hypoglycemia or I haven't eaten yet, and I'm diabetic, right? Oh, will you infuse dextrose with sugar or high dextrose lactated ringers to my IV? Or will you give me carbohydrates to oral route and let me eat my food? Which is better?
Through IV.
Glucose to IV.
To IV? Really? Remember, if you put sugar in my blood, you won't stimulate my pancreas faster. But if you feed me the carbohydrates and I can still eat, I have my gastric inhibitory peptide that can stimulate my pancreas to secrete insulin, and that insulin will put that sugar inside of my muscle faster. Did that make sense or confusing?
Yes, doctor.
Did everybody get that? That's why
Yes,
for
doc.
diabetic patients, as you can see, they always have something to eat sweet because they want to stimulate their gastric inhibitory peptide. Because that also is the one helping your pancreas secrete insulin. Okay? Lastly, your motility. Your motility is innervated by fat in the diet, acid, and nerve ending. They're secreted by the M cells. What do? They're the one increasing the motility of your GI tract. That's why they call it motility. Okay? So those are the hormones that you should know in your GI tract. Okay? Now we go to the types of contractions. We have what we call your propulsive peristalsis, in which your circular muscles do a contraction ring and a receptive relaxation. Contract, relax, contract, relax. So it moves the food along. When we want to mix the food, we do peristaltic contraction to local constrictive contractions. What do? Contract here, so the food goes back and forth. So you will have what we call your mixing action. So includes a segmental contraction and pendular movements of your peristalsis of your GI tract. Okay? So chyme, as you know, is propelled or pushed to the small intestines by your peristaltic wave. This wave is produced in response to stretch, what we call your myenteric reflex. They occur apart in the small intestine at around 0.2 to 2 centimeters. From here, it starts new peristalsis state and move a chyme in forward direction. Therefore, to do slow movement of peristaltic wave, usually it takes 3 to 5 hours are required for passage of that chyme or food products from your stomach going to your ileocecal valve to your large intestines. That's why at around 3 to 5 hours, you're already hungry. For Filipino, that doesn't apply because every 2 to 3 hours, we're always hungry. Right? For you guys, you eat breakfast at 6. Let's say you eat breakfast at 6. Before 11 or 12, definitely you're around hungry because the food has already reached your large intestines to 3 to 5 hours. Okay, but for the Filipino, if we eat at 6, we eat at around again at 9, sometimes at 10, and then around 12. And then we have another food at around 2 or 3, and another one at 6, and then goes also for the midnight snack. Do you do that now, my dear students, during the quarantine?
Yes, we do.
Yes, sir.
So faster peristaltic movement during quarantine, right? Okay, but normally it's around 3 to 5. Okay. So ingestion of food, when they say ingestion of food, the amount of food that the person ingests is determined principally by intrinsic desire or for food called hunger. The type of food that the person preferentially seeks is determined by the appetite. This mechanism are extremely important for maintaining adequate nutritional supply of the body. Do you know, have you experienced now in the quarantine, my dear students, what we call your cravings, right? Especially when you see it in the Facebook, when your friends
Yes,
post
sir.
delicious food. I like to eat that also. But subconsciously, your hypothalamus and your brain is telling you that you are deficient on that nutrient. There's a study that was done before. A man was trapped at an ocean, an accident in an ocean. He was able to survive by eating parts of the fish in which he craves for that day. And then when they research, those are supplements or vitamins that they needed for each day that for him to survive. What I'm trying to point is that your brain is telling you what nutrient are you deficient of, and then it will tell your hypothalamus, and you will seek for that food as your appetite. You get it? That's why you have your cravings. That's why they study obesity also that is related to the malfunctioning of your hypothalamus. Okay? The current discussion of food ingestion is confined to the mechanics of ingestion, especially in mastication and swallowing. Okay? So, mastication. This is your chewing, right? You might find it trivial or just small, but my dear students, this is very, very important in part of your digestion. My father, who's already 83, his gums has already receded. So there are no dentures that are capable to be fitted on his mouth. Also, there is a problem on implants. I'm considering giving him implants for the tooth so he could eat, right? But the problem is no dentist will operate on an 83-year-old male. So currently, I'm having a hard time feeding him because he has problems in mastication because of the tooth or the teeth or false teeth, right? So chewing food sometimes is difficult for him. So big chunks of food can lodge to the throat. It would be painful for the patient. Painful for the patient, they would rather not eat at all. Okay? So you might find it trivial for you because you have teeth and you're always chewing. But for patients that have problems in mastications, right? Even you guys, when you have toothaches, you don't have any drive to eat or chew food, right? So this is partially it's voluntary and partly it's a reflex, involuntary when you chew your food because once you lower down or relax your masseter, it is an automatic reflex that you put back your jaw and start masticating. Your dentition, your teeth, anterior teeth incisors for cutting, your posterior, your molars is for grinding. Most of the muscles are chewing are innervated by the motor branch of your fifth cranial nerve or your trigeminal nerve, and the chewing process is controlled by the nuclei in your brainstem. Mainly involves your mastication muscles, also stimulates the area of your hypothalamus, amygdala, and cerebral cortex near the sensory area of the taste, smell, often causes your chewing. That's why when you see food and you start salivating, it triggers your cephalic phase. And sometimes you go like this, right? Even if the food is not reaching yet your mouth. Okay? So swallowing. Please remember, propulsion of food to the mouth, to the stomach. Areas associated is the medulla, fibers of your vagus, and glossopharyngeal nerve. Cranial nerves involved in your swallowing are cranial nerves 5, 7, 9, 10, and 12. Please remember that. There are three phases in or stages in your swallowing. You have an oral stage, pharyngeal stage, and esophageal stage. Out of the three, okay, so this is the oral stage, and then this is the pharyngeal stage where it's enlarged in your soft palate in the back of your pharynx and enters now your upper esophageal sphincters as you go to your esophageal phase. Out of the three, as what I mentioned, oral stage is the voluntary phase. So my dear students, please be careful at anything that you put in your mouth. Okay, so that's voluntary. So initiates the swallowing. This stage of the tongue plays a vital role because your tongue or your cranial nerve number 12 pushes the bolus of food posteriorly to your pharynx. So the main cranial nerve that is involved in the oral stage is cranial nerve number 12. Okay, it's something you put your mouth, your tongue is the one pushing it back. So these are the process. Easy explanatory for reading. Your pharyngeal stage, what's the note here? These are the cranial nerves that is responsible for your pharyngeal stage. Remember, that's what I've said. Oral stage is the only voluntary. So you choose what you put in your mouth. But once it goes into the pharynx, it goes now to an involuntary stage where it is automatically and it cannot override unless you do your gag reflex. Contraction of your pharyngeal muscles pushes the bolus to the esophagus. So what are the cranial nerves involved? 5, 9, 10, and 12 as well. Okay. Last phase of your esophageal, your swallowing stages is your esophageal stage. This is also involuntary. This conducts your esophagus to the stomach at around 8 to 10 seconds. The upper third is striated muscle. It's still striated muscle. Question number 10. The remaining 2/3 are already smooth muscles. So the upper portion of your esophagus is still striated. This is mediated by vagus nerve, and the neurotransmitter is your intestinal peptide. The pull of gravity accelerates the movement of food, but if you like to be Spider-Man and Batman and you like to eat upside down, your peristalsis will also push it back to your stomach, but slower when you are upright and you have the help of gravity. Okay, so that is your esophageal stage. My dear students, please remember that when you open your upper esophageal sphincter, your lower esophageal sphincter will what? Open or close?
Close.
Hello? Close? Is it closed? When I open this, will I close this? Or when I close this, will I open this? Any idea? No answer? Oh, the answer is when you open your upper, you open also your lower. It is what we call your receptive reception of your gastrointestinal tract. I think I have a slide for that. Okay, so this is the phases again of swallowing. Your oral or buccal phase, which is voluntary. Your pharyngoesophageal, part 1, involuntary. And your esophageal, which is also involuntary. Okay? Now, okay, so your stomach, the motor functions of your stomach. Please remember, your stomach is there mainly for storage. Okay? Storage of large quantities of food until you can process it. Mixing of food is also primary function of your stomach. Mixing and storage. With gastric secretions, making it a semi-fluid mixture, which we call as your chyme. If you haven't seen a chyme, you see a vomitus that is chyme. Okay, it makes it into a whitish material. Slow emptying of chyme from the stomach into the small intestines. Anatomically, stomach is divided into two. Physiologically, it consists of an orad, which is the first 2/3, and the caudate, which is the remaining part. Your stomach, that's what I've mentioned, has what you call your vasovagal reflex. It helps storing the amount of food by interpreting signals from the stomachs and brainstem back to bulging it progressively outward, having a limit of 0.8 to 1.5 liters of food. Wait, I have a question. Chat. Wait, no. Okay. Wait. Okay. Through stomach, it will be absorbed. Wait, sir. But eating cravings all the time could cause someone to become obese. So how can someone be deficient in that nutrient but also has a... That's why they... good question, Dr. I mentioned also that's why they try to correlate the obesity as a malfunction of the hypothalamus, because that should give you satiety. When you say satiety, you are satisfied for what you eat. For obese persons, they are correlating it that there's deficient in the satiety center of their hypothalamus, making them crave more, making them eat more, hence obesity. Because if you already eaten what you are deficient of that nutrient, you should also be satisfied. But I guess most of you that are not obese, you experience that, right? You crave something when you're eating it, and then when you already eaten it, you're satisfied. You trigger your satiety center in your hypothalamus. Hence, I don't want it. I already eaten it already. Have you experienced that, my dear students? No, I have no students. Hello? You still there?
Yes,
No.
sir.
Yes, dog,
Okay.
yes, still here.
Okay, so I hope I answered that, Dr. Menso. Dr. Sono, sir, what is the pathophysiology of dysphagia? Dysphagia is difficulty in swallowing, right? So there are many factors or conditions that causes this dysphagia. First, one of the most common are your fistulas in the esophagus or paralysis in the cranial nerves, and also in the tongue. So there are many factors that cause difficulty in swallowing. You must, find the root cause of what's causing that dysphagia. So there are many pathologies for that. Sir, what is the mechanism by which drugs which stimulates vomiting or inhibit vomiting? Okay, good question, Dr. Sajem. What are the drugs which stimulates vomiting? There are no such drugs that can stimulate vomiting, but we can increase your acid, which can stimulate you to vomit if it's too much acidic, right? But to inhibit, there are plenty of drugs that can inhibit the vomiting. We block the medulla of oblongata for your gag reflex to be inhibited, or it's either that we decrease your sympathetic innervation to increase your parasympathetic, so that food can go there. You'll learn that in pharmacology. Okay, so what's to take out of this slide is that please remember, your stomach is able to store around 1.8 to 1.5 liters. If you're eating food and it is contained already in the stomach, right? It will send a efferent signal to your brain, to your cranial nerve number 10, vagal nerve, go to the 10. And what it will do, it makes your stomach relax. It will make it more relaxed, so it will be more receptive to food, to the point that that stomach can bulge to that relaxation. That's why when you eat, when you just finish eating, your stomach will bulge in front of you due to that vasovagal relaxation of your stomach. Did that make sense? I hope you got that, especially now you're about to eat dinner. So you just... Okay, so what do we call this? Your mixing and proportion of food. Okay, I think I should draw that so you can easily remember what I'm talking about, because I'm going to ask this definitely. Oh my God. Sorry. 1 minute. Okay. So, let's say this is your stomach. Okay. This is your stomach. This is your antrum and your cardia and your pylorus going to your duodenum. Okay. Your antrum, okay, is contracting to around 15 to 20 seconds per contraction. It produces slow wave. When you stretch it in the presence of food, you will contract it more, as what we said, right? As you contract the antrum and the body, this is the body, this is the pylorus, food will go here, correct? As you contract the antrum, it will go here. Can you still follow me? Or hello?
Yes,
doc.
doctor.
Okay, good. When you contract the antrum, okay, and produce slow wave contraction, food naturally will go to your cardia, to your pylorus. As you have learned, your pylorus has a sphincter here, and your duodenum is much thinner. So every time it contracts, it will only send chyme or food products small in the duodenum. Most of it will go back. It's like squeezing this, right? If you squeeze this, most of it will go to the duodenum, but some of it will go back to your stomach. So this is what they call as your process of retropropulsion. When you contract the antrum and the cardia, it will go to your pylorus and to your duodenum, and most of it, since it is a narrow opening, it will go back to your stomach. You do that 10 times, you're already mixing the food in your stomach. That's what we call physiologically your retropropulsion. I just made it the drawing so you won't have you can read it at your own free time. But I try to analyze it for you so you can understand what's happening to retropropulsion. Okay, was that clear? Confused?
Yes, doc, clear.
Clear. Okay. So chyme, remember, it's a mixture consisting of food and other digestive juices. This is appearance is murky, semi-fluid, or paste. Okay. So let's say you're on a fasting because you want to look sexy, or you're on a hunger strike because of your government. Okay. It is one if you don't have any presence of food. Okay. This often occurs when the stomach is empty for several hours. Let's say you didn't eat for 12 hours. This contraction can be rhythmic. When this contraction becomes extremely and strong, they transform to tetanic contraction, which lasts for around 2 to 3 minutes. That's the time your GI tract is talking to you. We call this as your hunger pangs. Hunger contractions are more common in young, healthy people and increase in persons with low level blood sugars. This contraction causes mild pains, which we call your hunger pangs, and do not begin until you don't have any food in your GI tract for 12 to 24 hours. Let's say you go fasting for one day. You'll experience hunger pangs that is very painful. But if you continue to do that for 3 to 4 days, since your body is already weak, that contraction will decrease. Eventually, that is more dangerous for your body. Let me repeat this statement. So hunger pangs is experienced when you don't have any food in your GI tract for 12 to 24 hours. It can increase in tetanic contractions. Okay, you can hear your stomach crumbling for 12 to 24 hours, which can give you pain sometimes. And if you continue it for 3 to 4 days, it will weaken. You won't experience any hunger pangs anymore. Eventually, that's dangerous because you can get sick. Okay, so intense antiperistaltic contraction during pyloric duct. Most of the time, it because rhythmic contractions of the stomachs are weak and contraction may lead. However, 20% of the time, I didn't ask any questions here. Pyloric empty. Okay, so regulation of what can empty your stomach to your duodenum. Stomach empties is regulated by the single signal of your stomach and your duodenum. Duodenum provides more potent signals to your stomach to stop gastric emptying time. What are those? Those are your CCK. Remember those? Your secretin, your hormones that can stop gastric emptying time. Okay, so this is self-explanatory one. Okay, so this parallel reflex of the pyloric pump, they inhibit the pyloric pump from pulsive contraction, increase the tone of your pyloric sphincters. Types of factors that monitored in the duodenum and can initiate enterogastric inhibitory reflex is when you distend your duodenum, it will stop gastric emptying time. The stomach will not empty it to the duodenum. Irritation of the duodenal mucosa, acid in the duodenal chyme of the mucosa. You change the osmolarity of the food of that chyme. Presence of breakdown product of the chyme, especially like proteins and fat. That's why, my dear students, if you eat a high protein diet and high fat diet, it takes more time for you to digest. Okay, because once it reaches your duodenum, it increases your it decreases your gastric emptying time. Okay, emptying of the stomach, as what I've said, CCK. We mentioned that during the hormones. That's why I encourage you to study the table that I presented to you a while ago. It's the same segmented contractions, small movement of the small intestines. Okay, so we go now to the small intestines. Peristalsis of the small intestines. This moves the chyme at around 3 to 5 centimeters. Net movement per minute is around 1 centimeter per minute. What controls the peristalsis? By the nervous and hormonal secretions of your GIT. What are those? Activity increased after taking a meal, presence of food will stretch it, right? Due to the stretching of the duodenal wall, also controlled by your gastroenteric reflex, your hormones, which affects the peristalsis. Hormones that increases the peristalsis of your small intestines are this one. Hormones that inhibits are your secretin and glucagon. Okay, question number 12, I think. Okay, so your propulsive effect of segmentation of movement, not much different from peristalsis, travels around 1 centimeter to the anal direction. We call this as your peristaltic rush. Usually, your peristaltic movement is weak due to an irritation of the mucosa, you can cause a peristaltic rush to your small intestine. Can anybody think of what can cause an irritation in your mucosa of your stomach? What can increase your peristalsis of your small intestines, my dear student? So, yes, Ali, what's that?
Coffee.
I cannot hear you. Oh, help me out. Come on. Sorry?
The coffee.
What do you think? Coffee?
Yeah.
Coffee can increase. Acid probably because of the acidity of the coffee, right? But what can irritate your mucosa? What's the most common irritant of your mucosa? What's the most common irritant of your mucosa, of your GI tract?
Gas.
Gas?
Acid.
Acid, yeah, probably acid. One is acid, but that's weak. What's more?
Gastrin.
What? Sorry.
Hydrochloric acid.
Hydrochloric acid? Acid also? How about if I have any bacteria or virus
Gastrin.
or peristalsis, parasitic infection? Would you think that would be an irritant? Food poisoning, bacteria, virus, and your parasite? Aren't those irritant to our gastric intestinal tract? Correct?
What about allergies, Doc?
Sorry, what's that, Dr. Pilar? What's that?
Allergies?
Allergies. Allergies, systemic or food allergies? Okay. Can cause what we call your peristaltic rush, or in layman's term, your diarrhea or diarrhea. Right? So please remember, my dear students, your diarrhea is not mainly your disease. It's one of the symptoms. That's why when I have patients that are suffering from diarrhea, I don't give them anti-diarrheal agents because I want that peristaltic rush. Why? Why do I want that peristaltic rush? So that anything that it's irritating in their small intestines can go out to the Game of Thrones, to the bathroom, rather than staying there in your GI tract. That's why when I have patients that are suffering from diarrhea, I'll just feed them with water or aerosol, and I tell them, do not stop that peristaltic rush, because that peristaltic rush is a defense mechanism of your small intestines. Have you seen a doctor giving, oh, this is diatabs, stop your diarrhea? Because as medical doctors, those are irritants. You don't want that irritant to stay there in your gastrointestinal tract. I remove that peristaltic rush, that irritant will stay longer in your gastrointestinal tract, can cause more harm. Okay? So do not take in anti-diarrheal agent. I even talked to my gastrointestinal specialist friend. The only time that he gave a anti-diarrheal agent to a patient because the anus is already bleeding from diarrhea. So he told me I cannot do anything. It's already defecating blood. Okay, so you need that peristaltic rush. Initially, oh, I have a question here. Wait, okay. What size of food should be small when food passes to the stomach to the duodenum? On liquid form, Ali. It should be already as a kind. That's why your stomach is mixing it. That's why I draw the retropropulsion. The only food size is in liquid form of chyme, which is highly acidic because you know it is coming from hydrochloric acid. Okay, so we have that feedback control of your ileocecal sphincter. The degree of contraction of your ileocecal sphincter is the intensity of peristalsis to the terminal ileum controlled significantly by the reflex of your cecum. Okay, what else? Okay, so lastly, I think one of the last slide is your defecation. The best feeling on earth, the success when you defecate, right? The act of emptying the feces all the way from the splenic fixture to the colon from to your anus. It is mediated weakly by your enteric or myenteric nervous system, but together with your parasympathetic, the intestine's peristaltic wave in descending colon, sigmoid, rectum to force feces into your anus. Let me rephrase that again so you can understand. Weakly, the peristaltic waves are weak via your enteric. It has to have another innervation, which is your parasympathetic. What do I mean? Normally, your colon will contract and send that chyme to your rectum and to your anus. But that's slow, right? It can be pushed further or pushed more powerful by the aid of your parasympathetic. As what Dr. Bautista is saying, parasympathetic is rest and digest. That's why, my dear students, it's very difficult for you to defecate when you are tense. Have you ever experienced you are sitting at the Game of Thrones in the bathroom or in your comfort room, and then you are defecating, and somebody came into that comfort room? What happened during your defecation? Did it proceed? Or at least no, at least when you're very intense, and then somebody knocked on the door of your comfort room. What happened to the feces? It went back up, right? Because you are tense. The rest and digest came out of the window. So you need both enteric and parasympathetic to push that and to follow up with your defecation. Okay, please remember you have two types of sphincter in your defecation. You have your internal anal sphincter, which has several centimeters long thickening of the circular muscles and immediately inside of your anus. This is controlled by the nerve fibers of your pudendal nerve, which is part of your somatic nervous system and therefore is under voluntary. Your external, okay, is composed of striated voluntary muscles and both surrounds your internal sphincters and extends distal to it. Conscious or at least subconscious control, subconsciously the external sphincter is usually kept continuously constricted. That's the one holding your feces in, your external. Okay, signals, but can be inhibited. You can inhibit that constriction. Okay, we have what we call your defecation reflex. Intrinsic reflex mediated by your local enteric nervous system on the rectal wall. Feces enter the rectum and distends your rectum. You will have afferent signals going to that myenteric textures locally, and it will produce peristaltic waves in the descending colon, sigmoid, and rectum, which forces the feces out of your anus. As peristaltic wave approaches the anus, the internal anal sphincter is relaxed by inhibitory signals from that myenteric plexus. So it's about to go out. A reflex or involuntary act can be voluntary, facilitated, or inhibited by you. Okay? Now, the first urge to defecate is when that feces reaches an intrarectal pressure of 18 milligrams of mercury. But that reflex can still be voluntarily inhibited by your external anal sphincter. Let's say pressure rises to your internal and external anal sphincter, right? At 18, you can still hold that feces in. But when it reaches around 40 to 50, and then that's the time you will see that feces go out in your underwear. Okay? That interrectal pressure, that reflex can still be voluntarily inhibited by your EAS. So if it exceeds 40 to 50, that's the maximum, you will let go of that feces. If the external anal sphincter is also consciously, voluntarily relaxed at the same time, defecation occurs. That's why you can voluntarily defecate. Okay? Intrinsic myenteric defecation reflex, functioning by itself, normally is relatively weak. To be effective in causing defecation, it is usually must be forfeited by another type of defecation reflex, the parasympathetic defecation reflex. That's why I told you in our example a while ago, you have to be relaxed when you defecate. Okay? Okay, so you have to close. These are self-explanatory. Okay, so please remember this as part. I think I asked 2 questions from this table also. So what are the excitatory agents that are inside of your gastrointestinal tract? This excitatory agents or neurotransmitter will increase calcium inside of the cell and then hence will increase the pumps of your enterocytes. CCK, also excitatory, released by your acetylcholine and substance P, and opioid peptides. What are the inhibitory agents? Of course, your BIP, your beta-adrenergic agonist, your norepinephrine and epinephrine, somatostatin, and again, alpha-adrenergic also, norepinephrine and epinephrine. So please take note of this inhibitory and excitatory agents. I think I asked 2 questions from that. Okay. Okay. So any questions so far in our